greetings everyone, and welcome to the online Optom learning series sessions. Today is the 77th session, and I'm very happy to welcome you all once again, the 77th time. Let me introduce to you all our speaker for today. So today we have Optom Isha Dave. She has earned her bachelor's and master's degree from the City University London. And after a few short years in the UK, she has now moved and relocated to Mumbai, India, where she not only runs her own practice, but she's also a visiting faculty at the Lotus College of Optometry, where she has her special interests in teaching contact lenses and clinical skills. Otherwise, her areas of interest are pediatric optometry, specialty contact lens fittings, and glaucoma screenings. And today, ma'am is going to talk to us about a very important aspect of dealing with our patients is the communication part. It's very important when we are sitting in front of our patients on how should we communicate, and that will help us to build the rapport and, you know, make patients with us for the lifelong. So welcome, Isha ma'am, onto our platform. Thank you very much.
Okay. Thank you so much.
Let me just leave the screen time to you. Yeah.
Sure. Thanks so much, Fakruddin. That's it's very kind of you to invite me to speak on this wonderful platform. So I'm very happy to be here. Good evening to everyone who's attending, and thank you guys for attending this evening, taking your time out to listen to this talk. I hope you find it interesting and useful, especially when it comes to seeing patients. So when I was preparing this talk, with communication, it does tend to be a very subjective thing and a very personality-oriented thing. Some people are much, much more confident and, you know, have sort of naturally good communication skills, whereas others may be a little bit shy and struggle a little bit more. So I just want to give you some basic guidelines to sort of take you forward in your optometric practice when you're dealing with patients on a day-to-day basis, to show you the best way to make your patients more comfortable and build a relationship with your patients. So, right, so I'm going to start with this slide, which represents something called white coat hypertension. Now, this is something I didn't know about before I started doing research for this particular presentation. So white coat hypertension, for those of you who don't know, is actually what happens is the patient's blood pressure is fine in their daily activities. They don't have any issues with blood pressure except when they step into the doctor's office. So the second they step into the doctor's office is when the blood pressure shoots up. And I thought this was quite interesting because I think this is such an obvious manifestation of the effect of anxiety on the physiological state. So this is your mind, literally what's happening up here, controlling what's happening physiologically. And it's quite it's quite a significant thing to address, because this is obviously very extreme, but it just goes to show that a lot of patients can be quite anxious or quite worried or quite scared about visiting any healthcare practitioner. And I'm sure you all have noticed that you get patients who are a little bit nervous for whatever reason. If they're elderly, they might think that they have, you know, cataracts and they're terrified about that. Or if they're younger patients or kids who don't want to wear spectacles and you're going to tell them they need spectacles. So this is a way of how to communicate and talk to your patient to make them feel comfortable, to release a lot of their anxiety, and just to make them feel like, okay, this person actually, you know, cares. You know, they're actually doing what's best for me. Okay. So what we want to do is avoid this kind of situation. So if you have a look at the doctor and have a look at the patient, I just want to draw your attention to the patient's face over here. Look how terrified he looks. And I want to draw your attention to the body language of the doctor, okay? And if you just observe how the doctor looks in this scenario, he just looks pretty blasé. He looks very apathetic, almost like, okay, well, I'm not really concerned about your fears and what you're going through. You're just going to have to deal with it. Okay. And the patient looks terrified. This is the type of situation that we want to avoid. Okay. We want the patient to be comfortable and happy and smiling when they're in your consulting room chair and when they leave. So how do we do that? So let's just look a little bit at the evolution of the doctor-patient relationship. So how was it at the very beginning when doctors first became a thing? And where are we now? So back in the day, and I'm talking back in the day, we're talking ancient Egypt, it was the physician's role was to fix, you know, so the physician will just do something to the patient will not respond, they'll just lie there, okay? And the clinical application of this model would be something like anesthesia, trauma if the patient's in a coma. So it's activity and passivity. So the doctor is completely active and the patient is completely passive. They're unresponsive to anything and they don't answer back at all. Then moving forward a little bit, it's guidance. The doctor guides and the patient cooperates. So the doctor tells the patient what to do, and the patient does it. They obey, no questions asked. But you will have a response from the patient, and the response will be, yes, doctor, okay, doctor, I see, doctor, right? Regardless of anything else. The doctor gives instructions and the patient listens. So this is moving further forward. And now where are we today? And this has been going on for quite some time, where now it's not so much about the doctor telling the patient what to do. It's about mutual participation. So it's an equal relationship between the healthcare practitioner and the patient. So you yourselves are healthcare practitioners, and this is about your relationship with your patient. So what is the healthcare practitioner's role? That is to help the patient help themselves. Now, if we look at diseases today, we're talking about chronic diseases, we're talking about chronic pathologies, we're talking about things where, especially in our profession, where the patient will keep coming back. Patients come back for regular examinations every year. So their treatment and their therapy is not necessarily you just telling them what to do, but a case of, okay, let's talk to the patient and help them help themselves. Okay, so this is where we are today, and this is what we need to maintain moving forward. And I'm sure you all have experienced that doesn't always happen. If you work in very busy hospitals or whatever, that doesn't always happen, where whether it's the ophthalmologist or whether it's you as the optometrist or wherever it may be, the patient doesn't necessarily get the time and the attention and the focus that they need for that particular patient. So we're going to talk about how we can sort of change that and make our practice a little more patient-centric. Okay, so here we are. We're going to talk about the medical model of how to deal with patients versus a more patient-centric model. So in a medical model, the patient's role is passive, practitioner dominates, the patient is just the recipient of the treatment or the therapy, and it's solely decided by the practitioner. And the entire treatment or therapy is based around the disease. Okay, so or the condition, whatever it is, the therapy is based around the condition and does not accommodate for the patient's lifestyle. Okay, now a lot of therapies may not be suitable or practical for that patient's lifestyle, but in a medical model, it doesn't matter. Nothing else matters except the disease and the treatment. Okay, practitioner does most of the talking. Now, what happens in this situation is, number one, the patient is not communicating their doubts and things that they are unsure of because they're not given the option to communicate that. And because of this, and secondly, whatever the treatment or the therapy is may not fit into their lifestyle. So it means that the patient does not adhere to whatever's been prescribed, okay? It does not comply to whatever's been prescribed. So now we're looking at more patient-centric models, okay? So The patient's role is more active. They're more involved. So they will take the time out. They should be allowed to ask questions. The actual treatment is a collaboration between the patient and the practitioner. So when the healthcare practitioner talks to the patient, it's not just, this is the problem and this is the solution. It's not that. It's, okay, so this is the problem and you have option 1, option 2, option 3, option 4. These are your options. So which option was best suited for you? Okay, there's always options. There's always different options when it comes to any kind of therapy. And it's a joint decision between the two. And of course, the therapy is customized for that particular patient, or the treatment is customized for that particular patient. So whether it's eye drops or whether it's vision therapy or whatever it might be, contact lenses, whatever it is, you need to customize it for what suits that patient and their daily lifestyle requirements. For that to happen, the practitioner has to do less talking and listen to the patient and ask them, okay, so how is this going to affect you in your everyday life? Once this has been established, once this relationship and this channel of communication has been established, the patient is more likely to open up and tell you, actually, this will work for me and this won't work for me. So then they're more likely to comply and adhere to treatment. Okay, so why is this all important? Okay, at the end of the day, why are we focusing so much on communication? Well, we have goals. So a short-term goal or a short-term outcome of good communication between the patient and the practitioner is trust, for starters. So the patient will trust you because you're listening to them. Second, patient recall. They will come back. They will have the intention to comply, and they'll be satisfied when they walk out the door. They'll be like, okay, we have a plan. The doctor understands me, understands where I'm coming from, has communicated my problem to me well, has given me options, so I'm going to go back. Secondly, the medium, so the mid-length sort of outcome is they will adhere, they will follow the treatment plan or the therapy that you have prescribed to them. And finally, long-term plans, you get good clinical outcomes. So whatever, there's a much better chance of alleviating whatever conditions, symptoms, issues the patient is having. They'll have an improved quality of life because of that. Plus, you've not really, by following these steps, you've allowed the patient to get treated while maintaining their lifestyle. And finally, the patient will stay with you. You have it's a benefit for you. So what do we mean when what approach do we need to have the patient towards patients? So first of all, courtesy. Obviously, you need to speak to them politely and courteously and respectfully. Reassuring, because sometimes patients can be very, very nervous. Offer support always. Say they should know that you're there for them, that they're not just another number in your appointment book, but you actually care about them. Be friendly, obviously, just be friendly and nice and have a conversation like you would with anybody else. Encouragement, so make sure you tell your patient, make sure you tell them that they're doing good, they're doing fine, everything's, just keep encouraging, keep being very positive. But the main thing, this main word that came up when I was doing all my research was empathy. Okay, now empathy is a complicated thing, I think. I think a lot of people, there are people who are naturally empathic. I'm one of those people, I'm naturally empathic. And there are other people who are not, and they really do struggle with empathy. So it's not necessarily, empathy is a big personality trait as well. So it's easier for some people and not so easy for others. And when I was doing my research, I read that healthcare practitioners, particularly doctors and surgeons, because of the way, something that makes them good surgeons and good doctors is that they lack empathy, which means that they tend not to get emotionally emotionally involved. So it means that, okay, you will be a very good doctor. Your diagnosis will be very good. Your surgery will be good. However, it'll be very difficult for you to connect and communicate with the patient. Now, us as optometrists is a little bit different because we're sort of in a more sort of paramedical field, and the nature of our relationship with the patient does involve a lot of communication. So empathy, if we don't have it naturally, is something that we should work on. Now, there are different types of empathy, okay? So the first type of empathy is cognitive empathy. And basically what that means is that you are able to understand somebody else's point of view. So somebody will say, I'm feeling like this, and you're like, okay, I understand. Then there's emotional empathy. Now, this isn't necessarily a positive thing. It's when you take on another person's emotion. So that becomes your burden. That's a very common thing in people who are naturally empaths. They tend to take on other people's feelings and other people's emotions, and that's not necessarily a good thing. This type of empathy is not necessarily a good thing when it comes to patient-practitioner relationship. So while you want to empathize and you want to be able to relate to what that person's going through, what you don't want to do is get emotionally involved and go home at the end of the day and still be thinking about that patient and what that patient's feeling later on. No, we don't want that. So actually the third type of empathy, compassionate empathy, is what we're looking for. So you're feeling, so you're understanding what that person's feeling, you're seeing their perspective, and you're taking action to help. That's what you want. So somewhere between cognitive and compassionate empathy is where you want to be, where you can relate to what that patient's going through, and you can show them that you're relating to them, but you're not taking on their emotional burden. You know, taking on a patient's emotional burden will affect your abilities as a practitioner. So the key thing is to understand where they're coming from and help them from that point of view, rather than getting too emotionally invested. So this is a very, very nice quote that I came across. The patient will never care how much you know until they know how much you care. So you could be the best doctor in the world or the best optom in the world, but if they don't think that you care and they don't think that you're going to give them time of day or that you're concerned about their problem, they're not gonna, it doesn't matter. It doesn't matter how good you are. Okay, and I think a key part of being a good practitioner is having a good relationship with your patient. So this is a very, very nice quote. I really like this, so I thought I would share it with you guys. Okay, so what are the different steps that we can take to communicate effectively? So first of all, assess what the patient already knows. Now we have the internet. So before the internet, before a lot of you were born, we didn't have the internet, and so it wasn't, so information was not so easily accessible. So we didn't have this, so patients would heavily rely on what the doctor is saying or what the practitioner is saying. In this case now, you can just Google everything. Now, the unfortunate part is when you start Googling health issues, eventually everything points to cancer, everything. So in these scenarios, that Google can be your best friend and your worst enemy. Having said that, you know, patients, an intelligent patient, for example, would sort of be able to weed out information that is not necessarily that's not necessarily appropriate to them, but works well, but will have enough information where they'll come to you and they'll say, okay, so I found out that this. So find out what the patient already knows. Okay, speak to them and say, okay, do you know what you're dealing with? Do you tell me what you know? Then assess what they want to know. So what does the patient actually, why are they here? So ask open-ended questions. A good question is, why are you here? We're going to talk about this a little bit more when we relate all of this a little bit more to optometric practice. Be empathic. We already talked about that. Slow down and listen. So what tends to happen is the patient will start talking, and I've seen this happen, and I've seen this happen with my students, I've seen this happen with other practitioners, where the patient will start to talk and the practitioner will just cut them off because they think they've heard a key word and not hear anything else that the patient has to say. So it's really important to let the patient finish. So slow down, take a step back and let the patient speak. Then, of course, when you're communicating with the patient, you must adapt your language based on the patient's intellectual and socioeconomic level. So, of course, you've taken the patient history, so you know where they are intellectually and in terms of education. So if you've got a very well-educated CEO, you're not going to talk to him like he's a child. And you're not going to talk to him like he's not already gone on Google and read everything. Okay, so you can be a little bit, or if it's a fellow healthcare practitioner, if it's an engineer, if it's somebody who's within the scientific field, they might have a better understanding or be able to understand a bit better than somebody perhaps who's not, or somebody who is of a lower educational level. So you have to adapt your language accordingly. So you want to keep it simple, but you don't want to insult the patient's intelligence. So you don't want to keep it so simple. So there's this very popular term that a lot of you may have heard of. It's called mansplaining. So you don't want to sound like, it's typically what mansplaining means is when a man is speaking to a woman as if she's stupid. Okay, so you don't want to be mansplaining things, but at the same time, you don't want to get too technical, you don't want to get too technical so it's beyond their comprehension. So you need to find a balance, and you also need to find a balance based on a judgment call that you have made according to what you perceive the patient's intellectual capacity to be. Always be truthful, okay? Don't try and hide the truth or hide behind sort of, or be vague or evasive. Be open and be truthful. The patient will always appreciate that. But also be hopeful. Say, okay, look, you do have this issue. However, we can try this treatment. Yeah, so you want to be truthful, but also be hopeful. Try and stay as positive as possible. You know, if the patient has, for example, if the patient has dry ARMD, you know that, okay, at the end of the day, the patient will probably lose their central vision. You know that. So you can be truthful about that. But then on the plus side, okay, you know, yeah, and we can't do anything about it, unfortunately, with geographic atrophy. Once it's there, it's there. However, it does progress very slowly, and there's a lot of advances in low vision that will help you live your daily, that will help you with your lifestyle in general. So this is what I mean. You be truthful, you tell them the truth, but also be hopeful and try and have a positive spin on things. Be wary of the patient's expressions and body language. So if you've said a word and you automatically notice the patient's become anxious, they've clenched, they're becoming uncomfortable, then you know that, okay, you need to reassure them. Don't just keep talking. Be aware of what they're saying, be aware of how they're responding to what you're saying, and then choose your words according to that. And of course, be prepared for a reaction. I've had patients cry because of certain issues. So be aware of that as well. Sorry. So non-verbal communication is also very important. So what do we mean by non-verbal communication? What we mean is, first of all, silence. Silence, you can communicate so much with silence. When you are silent, it gives an opportunity for your patient to talk. That is your non-verbal communication, giving the opportunity. So after the patient has said something or given you an answer, stay silent for a minute, for a few seconds, in case there's something else that they want to say. After you've asked a question, be silent. Give them an opportunity to think about how they want to answer instead of rushing them. So silence indicates the practitioner is listening. The other thing is body language. So what do I mean by body language? When you're nodding silently, but you're nodding, you're acknowledging that you're listening to them. You're acknowledging that you're understanding what they're saying. Position your body so you're facing the patient. So you're looking directly at the patient. So you're not looking somewhere else. You're not with your back to them looking at a computer screen. And when the patient is talking, don't make too many hand gestures because it's distracting. When you're moving a lot, the patient will get distracted and forget what they're saying, and they will also think that you're not listening. Facial expression is also very important. Maintain eye contact. So when the patient is talking to you, make sure you are looking at them so that they know that you are listening. It's very disconcerting. I'm sure you guys have just experienced this in a daily life. It's very disconcerting when you're trying to say something to someone or you're talking to them and they look down at their phone. And you think, well, should I continue talking? Or should I stop? Should I wait till you're done with your phone? Should I stop talking? Should I continue? Are you still listening? So it is disconcerting. It is important to maintain. And if you are going to break eye contact to make notes or whatever, make sure you make it clear that you're still listening. So you're saying, I'm just taking some notes, but I'm still listening. Keep talking, right? Make sure you communicate with the patient as well so they're not confused. Smile. Smiling goes a long, long way. If a patient is anxious and they walk in and they see you smile, now obviously with face masks, it's a little bit difficult, but you can smile. When you talk, they can hear you smiling. And if you smile wide enough, they can see your eyes smiling as well, even with a face mask. And I'm sure you guys have learned how to recognize smiles under a face mask now. But yeah, just be warm. Just a smile, it represents warmth, and that's what people want. People want you to be warm. It makes them more comfortable immediately. Communication traps. Now, this is where a lot of people often go wrong. Highly technical language or jargon, okay? So when you're using words, and I always say this to my students, and if some of you have been my students in the past, and I've been teaching you how to take a history, or I've been making you do role plays and things like that, you know, the student will say something that is something like myopia, and I'll have to turn around and say, I'm your patient. I don't know what myopia is. You know, they'll use a technical term like vitreous detachment, and you think, well, I don't know what a vitreous detachment is. It's very off-putting for the patient because you start saying these words, and then the patient is also scared to ask. Some patients are very confident and they'll straight away say, I'm sorry, I don't know what that means. But a lot of patients will not. A lot of patients will feel like, oh, if I ask what this means, then I might sound stupid, and they may not ask, you know? And that patient may not say anything, and they may say, okay, leave, but they're not going to come back. Not showing appropriate concern. So when the patient has told you what they're feeling or, you know, voiced their problems and you've dismissed it, not good. Not pausing, we already talked about this. So when you're not listening, not pausing, not allowing the patient to speak. And then not verifying that the patient has understood. So are you clear? Have you understood what I'm saying? Do you have any more questions? Okay. Do you have any doubts about the information I've just given you? That's a very important step as well. Using an impersonal approach or displaying apathy. So apathy is terrible when it comes to communication because it's cold. Apathy, in case you guys don't know, apathy is the opposite of empathy. So empathy is when you're being very personal and relating with the person in front of you. Apathy is literally not caring. I don't care. That's what apathy means. So when you're being apathetic, you're literally saying, I don't care. And no one wants to hear that. If you tell somebody something and they turn around and say, I don't care, that person's not going to speak to you again. So if that's a patient, they're not going to come back to you again. So an apathy, you don't have to necessarily say, I don't care. Your body language, your tone, all of the things we discussed earlier can display apathy, and that can be picked up by anyone. So that's a very important one. Not being available. So yeah, sure, you might be busy, but if you want to hold on to your patients, make yourself available. So let's translate all of this to optometric practices. So how we can apply all of this in our daily optometric practice. So when we do, so most of you are students, and some of you work in hospitals and clinics and et cetera, but as optometrists, your role is in primary eye care, okay? So unless you're in a highly specialized clinic, your role is primary eye care. So you're basically taking any patient and you're doing an examination. So now, as I'm sure most of you know, we follow the SOAP criteria when we're doing an examination, and a lot of you are students, so you must be following this notation when you are presenting your case studies, and we follow it for presenting case studies anywhere, conferences, talks, whatever. So what does it mean? Subjective, objective, assessment, plan, and education. Okay, so when you're seeing any case, this is your routine that you go through. So now, I'm not going through the actual routine, I'm going through the communication aspect of each of these things, okay? So let's start with subjective. So your subjective section in your primary eye care examination is history taking, okay? So when you first meet the patient, it might be a new patient, it might be an existing patient, you want to be clear, you want to be confident, and you want to introduce yourself. So, hello, my name is so-and-so. I'm going to be doing your eye examination today. Or if you know them already, hi, so-and-so, how are you? How are you doing? Direct the patient on where to sit. Don't take control. So as soon as a patient, that's what I mean by confidence. So if you take control, but in a friendly way, you're not sort of you're not the police, okay? You're just taking control in a friendly way. So you allow the patient in and you say to them, please come in, have a seat over there on the black chair, or have a seat at the desk, or whatever. You direct them where to sit, okay? Then you start by asking open-ended questions, such as, how are you? How can I help you today? Why have you come to visit me? When you ask open-ended questions, it just gives them an opportunity just to speak, rather than just yes/no questions, you know? You can get to the yes/no questions, but when you say, how are you, or how can I help, or what's your reason for your visit today, then they can immediately tell you if there's a problem or if there's not a problem or whatever it is, that you're allowing them to express themselves. If it's an existing patient, look at your previous records, and it's really nice when the patients, whether you really remember them or not, it's really nice when they think you remember them. So for example, quickly glance at the records, and if you've seen in hobbies that when they came last year or 2 years ago, they were playing tennis, something like, so are you still playing tennis? You know, just a general chit chat. An anxious patient will feel really comforted by general chit chat. And when you're doing your history taking, remember, it is a conversation, not an interrogation. Okay, so you're not interrogating them and throwing questions at them. It's a conversation. Keep engaging with the patient. Now, I mentioned earlier about eye contact. So, for example, when you're taking notes, I understand you're writing as you're talking. So take your notes, but look up and go, yeah, and you're writing and you're looking, you're writing and you're writing down and you're looking at the patient and you're writing. And make sure that if you're going to have your head down for more than a few seconds, then say to the patient, keep going, I am still listening, I'm just taking notes. Communicate with the patient. And then when you've finished your history section, give them an opportunity to tell you anything that they've missed or they wanted to say before and they think, oh, that moment's gone, I can't say it. So give them an opportunity to say, so is that it? Was there anything else that you wanted to say? Have you remembered anything else that you never mentioned before? You know, so it just gives them that comfort of saying, okay, I have the freedom to say whatever I want. I've seen a lot of practitioners kind of, you know, be impatient and kind of trying to hurry the patients along. I understand you have patients waiting, but this will really ensure that your patient comes back to you and your patient also complies. So then you're objective is your routine clinical test. Now, the tests listed over here, everybody is doing all of these tests, I'm sure. Okay, so now what are we going to, what do we need to do during the clinical tests to make the patient feel more comfortable? We're poking and prodding at their eyes, we're holding things in front of them, we're making them read, we're asking them 300 questions. So, you know, how do we make the patient feel comfortable, and how do we effectively communicate with the patient so we're not wasting time, not wasting our time during the test? A lot of the times, poor communication will lead to the patient not understanding. So then you get bad test results, you get bad refractions, you get bad results on everything, slit lamp, ophthalmoscopy, everything, because you just can't see because the patient's not cooperating. All the patients always want to cooperate. It's not that they don't want to, it's just sometimes they don't know what to do. They don't know where to look because the practitioner is not giving them appropriate instructions. So give clear instructions. So, until which line can you clearly read without straining? Very, very clear question. Please tell me if the letters appear just as clear with this lens or better without it. So very, very clear. It's much better to actually ask a question properly than to just be like, with or without. With or without what? Where? What did you show me? I don't know. What am I looking at? Right? So these are things that are going on in the patient's head. You haven't told them where to look. What am I looking at? With what? Without what? I don't know. Right? So you're not asking questions appropriately. The patient's not understanding. And then finally, they're just going to get terrified and just like, you know, say whatever they think you want them to hear. Please inform me if you feel any pain during this procedure. The patient might be in a lot of pain, but not saying anything because they're scared to say anything. They won't come back. So make sure you communicate this with them. So we have a little poll now, I believe, the first poll. So you guys are all either students or practitioners. So can we have the poll, please, Fakbinan, the first one? So the text box says, please keep moving the text closer until it starts to appear blurred. So just out of interest, which measurement do you think is being taken here? So if I've communicated this well, you guys should be able to tell me which measurement is being taken. Actually, it is amplitude of accommodation. How do I know that it's amplitude? Because in near point of convergence, so some people will know it as amplitude of accommodation, other people will know it as near point of accommodation. Okay, so please keep moving the text. So when we're doing near point of convergence, we have a point, not a text, and we ask about double vision, not blurriness. So that's why we know this is amplitude or near point of accommodation, because we're looking at text and it starts to appear blurred. Okay, place your chin on the chin rest and your head firmly against the headrest. You must, when you're doing slit lamp, as you know, if the chin is not on the chin rest or the head is not against the headrest, you're not going to be in the right plane and your slit lamp will just not focus. All of my previous students will know this, obviously, and I think all practitioners will also know this, but you must communicate it to your patient. Keeping your head still, follow the light with only your eyes. You don't waste time telling the patient again, no, 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 don't move your head. Keep your head still. If you've given a clear instruction at the beginning, patient knows exactly what to do. Okay, so we have a second poll here. Hopefully we don't have any mistakes in this poll question. So while maintaining your fixation on the, okay, great. While maintaining your fixation on the central light, please press the button whenever you notice a light appear in the periphery. Yeah, is perimetry. That's correct. Most of you got that right, so that's excellent. But if you notice the way that I phrased it, while maintaining fixation on the central light, so the patient knows that they should only keep looking at the central light. Press the button whenever you notice, not whenever you see, because that means that, okay, I have to turn my eyes to see. But whenever you notice, that means you're noticing something in your periphery rather than seeing it. Okay, so these small, subtle changes in your words can actually make a difference in the patient, in how the patient does the test. Perimetry for ophthalmologists, perimetry is a notoriously irritating test because the patient doesn't really understand how to do it. So it's very, very important that you give them a really good explanation, whatever language it is. You take the time to make them explain, because then you'll show the optometrist, show the opthal a test with fixation losses, false positives, false negatives. It's all over the place. Ophthalmologist is very, very irritated because he's like, this test is completely useless to me, right? So the importance of communication, good communication. Please keep looking at this red light. So again, you're instructing the patient where to look, making your life easier and the patient's life easier, because then they don't have any doubts. They're not confused about anything. Okay. Second thing, keep the patient informed throughout the examination. So keep telling them what you're doing, because sometimes they can get very nervous. Like a lot of patients will get very nervous and not know what's going on, and suddenly their head is on this thing and they think they're in an electric chair. They don't know what's happening. Don't forget that as students, you guys have been practicing on each other, right? So you all know exactly what's going on, but the patient does not. So it's really, really important to keep the patient informed. So the light may feel a little bit bright. Please bear with me. If you don't tell the patient that, they're like, oh my God, this light is so bright. Is there something wrong with my eyes? Do they know that this light is too bright? Is this light going to damage my eyes? These are all the thoughts that are going through the patient's head. But if you tell them it will be bright, that's normal, they'll be like, okay, fine, let me just bear it. It's uncomfortable, but let me just bear it. It's supposed to be like this. This instrument is a microscope. I'm using it to examine the health of your eyes. So you're just, instead of the patient, you're just placing the patient on the microscope and just starting, you tell them that, look, this is what I'm doing. You know, it just makes them feel more comfortable. I'm just examining. So they know, okay, I'm not necessarily going to touch you. And then when you're examining, when you say, for example, when you lift the lid, or when you go to avert the lid, tell them what you're doing. Say, I just want to look underneath your lid. It might feel a little uncomfortable. Just communicating with the patient to make them feel at ease, that whatever they're feeling is normal. Okay, I think we have another poll here. I'm applying this stain in your eye to examine the health of your tears. It will not affect your vision. Can we have our third poll, Fakhruddin? Okay, so it is actually, the correct answer is proparacaine, because the key word here is the word stain. Okay, I am applying this stain in your eyes. So fluorescein is a stain, lissamine green is a stain, rose bengal is a stain. It could be any of these three, but it's not going to be proparacaine, because proparacaine is not a stain. So what is the least likely substance? The least likely is proparacaine, because it is not a stain. Okay, but this is just so what happens, and what I have noticed a lot of people doing, is they just lunge at the patient with the fluorescein strip or the lissamine green strip. You just lunge at the patient, and the patient sees this thing coming towards their eye and they don't know what's going on. When that happens, you're likely, number one, to upset your patient because you're touching the eye and you haven't warned them. And secondly, they don't know where to look. They don't know, and they could look anywhere, and you risk abrading the cornea. So always approach slowly when you're doing anything invasive, and inform the patient that I'm just going to put this stain in your eye. It's not going to hurt. It's not going to affect your vision. A big one, this one, I will be checking your eye pressure. I have seen so many practitioners do this. They just don't warn the patient about the puff of air when they're doing non-contact tonometry. And it's very scary for the patient, very, very scary, especially if they've never had it done before, okay? I will be checking your eye pressure. You will feel a small puff of air. It will not hurt, but it might make you jump. It does. Everybody, you've all had non-contact tonometry done on you. And it does. No matter how much you're expecting it, it still makes you jump, right? Still makes you blink. So tell the patient what to expect in advance. I'm taking a photograph of your retina, which is at the back of your eye. You will see a bright flash. It's better that they know, so that they don't get shocked and blinded by this bright flash of light. Okay, another poll, our last poll for the day. So it is normal for these drops to burn for a couple of minutes after installation. So which drop could be referred to here? Which drops, and I'm sure all of you have had that in your eyes, and it's a very common drop that we use for diagnosis and practice, especially in clinical practice. Okay, so yeah, and again, this is something that I've seen so often, and I've seen it in Lotus, and it's the students that are putting the drops in the patient's eyes, and they put the drops without even warning the patient, and that poor patient will just sit there in agony because it really does burn. Like even me, I've had the drops in my eyes, and it really, really does burn. So it's always nice to say, listen, I'm really sorry, but it is going to burn. Sorry. But at least they know what to expect, right? Rather than you just shoving a drop in their eye and then they're just sitting and thinking, is this normal? Is this not normal? Okay, so communicate. Next thing, always keep checking in and reassuring. So while you're doing your examination, keep talking to the patient. Are you comfortable? Don't worry, it won't hurt. Putting in a soft contact lens for the first time, people are always terrified. So it's always nice to say, don't worry, it won't hurt, or whatever, putting in fluorescein, averting the eyelid, because it doesn't really hurt. It's a little uncomfortable, but it won't hurt. But if it's gonna hurt, then don't lie. Like the drops, if it's gonna burn, then say, yes, it will burn. Tell them the truth, like I said before. Would you like me to adjust the height? Sometimes the patient is just really uncomfortable in that chair while you're doing your slit lamp examination or while you're doing your indirect ophthalmoscopy. So it's nice just to ask, are you comfortable? Would you like me to adjust the height? Take your time, there is no rush. So when they're answering your questions, when you're doing a refraction or when you're doing perimetry, they shouldn't feel pressure to rush through the test. That's when you get inaccuracies. Don't worry, there are no right or wrong answers. This is specifically relevant when you're refracting, because people are just so worried about giving the wrong answer. So if you tell them from the beginning, listen, there's no right or wrong answers, just answer truthfully. Like whatever question I'm asking you, is it clearer with this lens or clearer without this lens? Answer whatever you feel, right? So there are no right or wrong answers. You as a good optometrist will be, and once you've done enough refractions, will be able to judge. Do I trust this patient's answer? Do I not trust this patient's answer? Those of you who have been taught refraction by me from Lotus, you will know we've done many of these scenarios where you think, okay, do I trust this patient's answer? Am I going to give them that minus? Am I not going to give them that minus? That's your decision as a practitioner. But as far as the patient's concerned, they should not feel any pressure. You can't turn around to the patient. Are you sure? Are you sure it's clearer? Are you sure? No, you can't do that. Okay, because then you're sort of pointing them. Just say, don't worry, there are no right or wrong answers. Let them comfortably answer and you make a decision. It is completely normal at your age. So people get freaked out when they hit presbyopia. People get freaked out when you tell them they've got early cataracts. People get freaked out when they get PVDs. So tell them it's normal. This is normal. This is normal. This happens to everybody. When people get freaked out about cataracts, which they do, for us it's normal because everybody gets it and we know that. But for a patient, oh my God, I have a cataract. It's a lot. I say to a lot of them, say, look, if everybody lived to 100, everybody will get a cataract at some point. Okay, so say it's normal for your age, whatever it is. Obviously don't lie, but tell if it's presbyopia and they're in their early 40s, it is normal for their age. So keep them reassured. Okay, so moving on to the next section, the assessment and the plan. So this is really important, okay? So now, if we go through all the beginning, if you have a look at everything, the way that we've communicated with the patient, top to bottom, from the beginning, we've been very open to listening to their history. We've made them feel very comfortable while examining their eyes. Now we've done their examination, we've decided on the diagnosis, and now we're going to discuss with the patient, okay? You're going to explain to them your findings. I have a very nice poster right next to my consulting room chair, which is just a poster of the anatomy of the eye, cross-section of the eye. And I use that very regularly. I say, so this, I'll point, I'll say, this section over here is your retina. This section over here is your cornea. This is what's affected. This bit in the middle is the jelly inside your eye. This is what's affected. They find that really useful because a lot of patients are scared to ask, like scared to say, I don't really understand what the problem is, okay? Then, of course, you have to relate your findings to the initial complaint. So the complaint that I'm seeing a lot of floaters recently and the patient's in their 50s and they've got a posterior vitreous detachment, then you're relating the two, but you're explaining to them very clearly that it is a posterior vitreous detachment, but you're in your 50s, so it's normal. However, we still need to keep checking your eyes, etc., etc. Give the patient an opportunity to ask questions. So is it going to happen in my other eye? Would it have happened to both eyes at the same time? Will it never happen to? So these are questions that the patient might want to ask, and you can go ahead and say, do you have any questions? Have you understood? Then you discuss your plan of action. So if the patient has a cataract, you say, okay, well, you know, I am finding cataract, which is why you're not seeing as clearly as you were before. So perhaps it's time for you to get your consult with an ophthalmologist for an extraction. Keep it all very positive, very normal. A cataract surgery is very routine, has a very high success rate. It's nothing for you to worry about. So all of these things discuss, it's a discussion. Let your patient ask you questions. How urgent is it? Do I need to do it next week? Do I need to, can I go next month? Etc., etc. So you're saying that, so I've had many situations where I've said to the patient, you know, I really would like to do a perimetry because of your family history of glaucoma or whatever. And the patient will say, is it very urgent? Do I need to come back tomorrow? I'm a little busy this week. Can I come back next week? So when you're discussing it with your patient, you're giving them different options. This is what I was talking about before. Finally, ensure that they have understood, so this is what we talked about before, have you understood the diagnosis and why you are prescribing the treatment and the therapy? So it is backwards and forwards. It is a discussion. Now, but a lot of practitioners still do that. They still speak to the patient, finally educating them. So how are we moving forward on this? Okay, this section is really, really important for good compliance. Okay, so for example, we keep talking about compliance when it comes to like contact lens hygiene. Okay, so how do we make sure that they're going to comply? So if you have a look at this graph over here, how much information does the patient retain? So you keep talking at them, talking, and eventually they're going to stop listening. Like I'm sure a lot of you guys have stopped listening now while I'm speaking to you. So, but maybe some of you are still listening because of this lovely presentation that I've made for you. And with me talking and you guys looking at the presentation, you're definitely more engaged, right? Because you can hear my voice, you can hear that I'm animated, and you can see all these pretty pictures in front of you. So always good to show them, give them, explain while pointing, like I said, and always give them material to take away. So these are some terrible pictures that I took at the last minute of some of the material that I give my patients in terms of contact lenses or myopia or glaucoma or whatever else. Don't ever let them leave empty-handed, because they're going to go home and forget about 90% of what you said. So they will, at least if you give them something to refer to, they can refer to that. Not just that, I also share a lot of links, a lot of YouTube videos, lots of stuff online. We have all these resources, amazing resources that we have access to now for free. So we can always share that with the patients, and they really appreciate that. Also, give them the option to get in touch with you whenever they want, to speak to you, to call. If you have any questions, please call anytime, come visit, just give us a call and take an appointment. So it shows them, remember there was one of the steps which said make sure you are available for the patient. So that's what they mean by availability. They don't mean you better reply to my message at midnight if I call you and tell you my eye is hurting. That's not what it means by make sure you're available. What it means is make sure you're available to answer questions. So if they go home and think of something that they didn't ask you, they shouldn't be like, oh my God, that's done now. They should have the option of calling you the following day and say, by the way, I forgot to ask. So then it just improves the relationship between the patient and the practitioner. So in conclusion, after that very, very long traumatic experience of the internet that we've had just now, be kind and empathic. Customize your approach for each patient. Remember, each patient is different. Some patients will come in guns blazing, very confident, know exactly what they're talking about, and think they know everything. Those are patients that you need to sort of bring down to earth a little bit. And then you've got the opposite end of the spectrum of patients who are very shy, very anxious, may not know, may be scared to ask questions, and you need to have a more gentle approach with these patients. So you have to try and judge that, and you will. You can judge other human beings based on their behavior and characteristics. You do it every day. So it's just applying daily rules to your consulting room, okay? And if you apply those same rules, the same kind of respect that you would give any other person to your patient, and just treat them like another person, they will be much, much more open to your treatments and your therapies, and much more compliant. At the end of the day, we want good compliance. So why? Good communication means good adherence, means good clinical outcomes. Good clinical outcomes is what we want at the end of the day, because finally, from a very, very selfish perspective, we don't want the patient going away. We don't want to lose the patient. So if you show good clinical outcomes, the patient will keep coming back to you, because there will be many scenarios where they've gone to 8 different doctors or 8 different ophthalms or 8 different optoms with the same problem, and nobody's been able to solve their problem, but you did. Why? Because you just communicated with them a little bit better. 90% of the time, it's just a breakdown in communication that causes issues, and not that the other person was a bad practitioner. They probably are a good practitioner, but they just didn't communicate the problem well enough for the patient to really understand and comply. However, having said that, there will always be patients who test your patience. So you will need to maintain some decorum in those situations. Okay, so that's all I have for today.
Thank you, Isha ma'am, for that very, a timely talk, I would say. This is really important, and it helps us to be better practitioners. Communication is the key. And I like your quote, your personalized quote where you mentioned. I saw the name there. That made me quite.
Well, it is an Isha Dave original, I think. I'm sure people have said it before, but I'm claiming it. So.
Yeah, you are claiming it. So yeah, there will be some category of patients which will definitely. But I think you did probably miss out on some discussions which were going on. So. Just really appreciate the comments by Mr. Fun. He did mention that when we lost connection, he started the conversation saying that he had a patient who didn't appreciate the anti-reflective coating, what they were suggesting. And in the end, since the patient did not want to have that ARC coating, they had to give him an uncoated of a high end. But at the end, patients started to appreciate that we were right. So it's really important for us to understand, and sometimes patients have their own opinions as well, right? And there was one.
Yeah, for sure. I think it's bit iffy, but I think it's someone's just, sorry, I got distracted with a question that said considering the COVID scenario.
Those questions, we are just gonna take those questions later, but I was just mentioning Mr. Fani's experience, which was kind of interesting, and sometimes Yeah, as you said, patients might have their own thoughts. They might have Googled up a lot of things and come up there. So you have to really have
Okay,
that.
so I'll give you guys a really good example of during lockdown, the blue light question, the blue light that's coming from screens. Now, all of us who are academicians, I don't know that's a word, but all of us who are in academics will have done our research and will know that, okay, a lot of what these companies have done is very smart. They've said blue light harms the eye, correct? And computers emit blue light. That's it. That's the only information they've given. Blue light harms the eye. Correct information. That is correct. Computer screens emit blue light. Also correct information. What they haven't talked about is wavelengths of blue light. So, so then we know that blue light from a computer does not necessarily harm the eye. However, I had a massive influx of patients who were like, I need to get blue light protectors for my child. So, you know, this is what I mean. And they're like convinced, no, I have to. And you can say, look, you can if you want, it's not going to harm you, but you don't have to like get anxious and go nuts over it because, you know, it's not that important. So it's just a case of like, again, communicating things to patients in a very gentle way, especially when it comes to their children.
That's right. And a student is mentioned, Mr. Srihari Konar, I hope I'm pronouncing your name correctly, mentioned that the psycho-education of patient plays a major role and would bring out better compliance, specifically in diagnostic purposes. So I think the last section where you mentioned about communicating with them properly and letting them know and letting them understand what's happening will definitely let us be more compliant, a patient be more compliant in diagnostic procedures. This
COVID question.
How to gain confidence of patients so that we count them as a loyal customer for us in clinical practice? Any tips you would want to share on this particular concept?
Well, everything that we've discussed in this entire presentation, like everything, it's just communication. And obviously you have to be a good practitioner. And so your results have to reflect everything that you're saying. So that helps. To have good clinical skills also helps. But in terms of maintaining, in terms of a patient being loyal, it's just the relationship you build with them. That's what loyalty is all about at the end of the day. Don't think of it as a patient, think of it as a person. Don't think of them as a customer, think of them as a person. You know, how do you've got friends and people around you, how do you ensure your friends and your family stay loyal to you? Right? It's the same thing. It's just how you speak to them and you give them the same respect that you would like for them. It's the same thing. And show them that you care.
Yeah. And one more question is, pertaining to the current scenario, we are actually wanting to reduce chair time, but you know, communication takes kind of a bit time. Any tips you would want to give on this particular aspect?
Yes, definitely. Do the communication on a video call.
Yeah, as we are doing now.
So be like, as we're doing now. So do your history, all of that on a video call. Let the patient come in, do your examination with all your gear on, say out, get home, give me a call, or I'll give you a call, and have all your discussions on there. Communication does not have to be, in fact, it might even be more effective because you're like it's just one-on-one communication. There's no other distractions, there's nothing else going on, there's no phone ringing or anything like that. The purpose of this video call is to communicate. So it might even work better. So yeah, there's my tip and trick for the COVID scenario. That
I think reflects with the same. I think we did have a session with Ukti. She talked about teleoptometry practices, and we have a good discussion saying that patients might be more comfortable when you're doing a video call because patient is at the comfort of his or office of.
That's also true. Yeah.
And they will be more opened up in talking to you, and that might have a better communication compared to when you're sitting, because when you're sitting in front of them during COVID, they are scared, you are scared as well. So
yeah,
that's probably a barrier. And as you mentioned, communication should not be a barrier. I mean, you can do it online, that's not a problem.
Yeah. Okay.
Yeah. Thank you very much, Isha ma'am. I think it was a wonderful session. Thank you so much.
Thank you, guys. Okay, no, thank you. Thank you guys for being so patient and listening to me talk for an hour. I do enjoy talking, so, I appreciate that. All right, thanks, guys. Thank you very much. And feel free to get in touch with me if you have any more questions.
And just for everyone, we do have session tomorrow on the same time. Tomorrow we have a session on age-related macular degeneration, a general overview. So would appreciate if you guys can join in. It's at the same time, 6:30 late evening Indian time and 9 p.m. Malaysian time. Thank you, everyone. I hope to see you all tomorrow again. Take care. Be safe. Bye-bye.